اشكركم على صمودكم لغايه الوقت دوت. احنا سريعا مش هناخد اكتر من 10 دقائق ان شاء الله. هنتكلم على حاجه صغيره قوي على الدايليما بتاع البوست بيدياتريك ليفر ترانسبلانت كومبليكيشنز. باختصار احنا عندنا الليفر ترانسبلانت بنعتبره حاليا ذا لايف سيفنج بروسيجر والاونلي كيوراتيف لبعض الديزيز اللي بتاثر على الليفر، منها الاكيوت بالمنت ليفر فيلير او الحاجات الكرونيك زي الحاجات الميتابوليك زي الويلسون اللي بتحسن الكواليتي اوف لايف بوست ترانسبلانتيشن. indications بتاعت الترانسبلانت مين اللي هو البيليري اتريزيا عندنا في الاطفال، followed by الحاجات الميتابوليك وبعد واقل حاجه الكوليستاتيك المالجنسي، ده اقل حاجه عندنا في الترانسبلانتيشن. طيب بوست ترانسبلانت كومبليكيشن، والهدف منها مش ان احنا نتكلم على ال 24 hours او ال 48 hours بوست ترانسبلانت للناس اللي مش بتشتغل ترانسبلانتيشن، لكن الهدف الحقيقه ان احنا نعرف انه الكومبليكيشنز may come after 1 year، فالعيان عادي خالص انه يجي الاي ار اللي جنب بيته او قريبه منه علشان حصل اكيوت كومبليكيشن او كومبليكيشن جاي بيها. الحاجات السيرجري اللي بتحصل في الاول هو الهيباتيك ارتري ثرومبوزز، البورتال فين ثرومبوزز، البلياري كومبليكيشن زي البلياري ليك، والحاجات الاكيوت ريجكشن اللي بيحتاج ري اوبريشن وري ترانسبلانتيشن. النون سيرجري هو الجرافت، النون فانكشن، السابسز، الهايبرتنشن، النيورولوجيكال كومبليكيشن، وده المين اللي هنتكلم عليه النهارده، وحاجه اسمها 7 داي سيندروم. هنبتدي بتو كيسز وهنكمل النيورولوجيكال كومبليكيشن بتاعتنا مع دكتوره ديانا.
Okay, this is the case one. This is case one. This is a 10 years old female patient. She is a known case of progressive familial intrahepatic cholestasis. Underwent liver transplant. The patient received a left loop graft. The graft to recipient weight ratio was 1.4%. The intraoperative course was straightforward. The reperfusion was uneventful. She was transferred to BQ for postoperative care according to enhanced recovery after surgery protocol. She had stable hemodynamic data with no vasopressor requirement. Severe serum lactate levels were below 2 millimole per liter. She receives pulse steroids intraoperatively before perfusion. And then the patient started full dose steroid from day 1 postoperative. The patient started tacrolimus with a target therapeutic level of 8 to 10 nanogram per millimeter was started from day 0. And her blood pressure was high on the third day post-operative, which settled with oral antihypertensives. And then at day 5, on day 5 post-operative, the patient developed 2 attacks of generalized tonic-clonic convulsions. Each one lasted for 2 to 3 minutes and aborted spontaneously. Physical examination showed that the patient has arterial blood pressure of 160/100 millimeter mercury. Immediate initiation of intravenous nitroglycerin was done. Tacrolimus level was done, and CT scan of the brain didn't reveal any abnormality. And so we did an MRI. An MRI brain showed increased signal intensity of on T2, weighted and flare sequences of the posterior fossa, the posterior segment of both cerebral hemispheres, the posteromedial segment of the occipital lobe, bilaterally with great hyperdensity. هو موجود هنا في البوستيريور بورد. وده كان كاركترستيك للبوستيريور reversible encephalopathy syndrome. Tacrolimus was seized, and whereas intravenous antihypertensive medication was continued. Then the patient became normotensive after that, after we started the medication. So we withdrew the medication gradually. Follow-up an MRI on day 15 showed that near complete regression of symptom in the previously affected area. So the tacrolimus was reintroduced again, and the patient has been free of breath and related symptom during the follow-up period. This is the case 1. And we have another case, case 2. This is a patient, an 8 years old male patient with a diagnosis of Wilson disease, underwent liver transplant. Also, the patient received a left loop graft. The graft to recipient weight ratio was 2.2%. The intraoperative course also was straightforward. The reperfusion was uneventful. And then the patient transferred to BQ for postoperative care. His dynamics were stable, but the patient need a low dose of vasopressor. Serum lactate also were below 2 millimole per liter, and kidney function was normal. Also, pulse steroid was started intraoperatively, and then we gave it from day 1, full dose steroid. Tacrolimus also started from day 0. And we started aspirin from day 2 after the establishment of drain output. On day 7 post-operative, he developed left upper and lower limb weakness. CT brain was done, show hypodense lesion on the right hemisphere. MRI and MRV stroke protocol was done and showed middle cerebral artery occlusion. Immediately, we started the low molecular weight heparin with physiotherapy.
Neurological complications post transplant is one of the common complications اللي احنا بنشوفها في البوست ترانسبلانت اريا ايرا اللي بتوصل لتقريبا اراوند نص العيانين بتوعنا بيعاني منها. usually بتحصل الماكسيمم في اول اسبوعين، لكن زي ما قلت لحضراتكم may extend to the first year post transplant and neurological complications. Maybe seizures, maybe encephalopathy, maybe central pontine myelinolysis, cerebral vascular stroke accident, extrapyramidal manifestation, and very rare we have a peripheral neuropathy, Guillain-Barré syndrome, and we have a patient with diaphragmatic paralysis post-operative post-transplant, and she developed diaphragmatic paralysis and was diagnosed after 2 months. Seizures is the most common. It's about 40% of the patients. The commonest type is generalized tonic-clonic convulsions. Tacrolimus and steroids are the potential trigger factors for seizures, which may be caused by electrolyte imbalance, may be caused by metabolic imbalance, by hypoglycemia, hypomagnesemia, hyponatremia, and opportunistic infections. We have a patient presented with excessive sweating out of brainstem meningitis post-transplant by 1.5 years. CNS hemorrhage affecting any part in the CNS. MRI mostly is the most common MRI finding is breast. It's related mainly for calcineurin inhibitor, which is tacrolimus, because it directly inhibits nitric oxide, causing vasoconstriction in the blood vessels of the CNS, causing cellular apoptosis and a change in the blood-brain barrier. Tacrolimus also interfere with GABA receptors for transmission by inhibiting lambda-induced neurotransmission, and it causes direct neurotoxicity to the brain. Encephalopathy is reported in about 35% of pediatric liver transplant patient. It's caused mainly by impaired graft function, sepsis, uremia, acute kidney injury that may be part of a post-transplant complication, tacrolimus and steroids, and the occurrence of a central pontine myelinolysis. A differential diagnosis of a prolonged unconsciousness in a patient post-transplant, we have to be sure that the patient didn't receive benzodiazepine, because in the post-transplant era, the benzodiazepine T-half is prolonged. Hemorrhage because platelet consumption and prolonged INR post-operative, and meningitis out of opportunistic infections. Stroke caused in about 60% of liver recipient. It's mainly caused by anticoagulation in the presence of low platelets. Central pontine myelinolysis, it's a very serious complication because of الosmotic shift خاصة مع rapid correction للhyponatremia and extrapyramidal manifestations. It's less seen about 0.5 to 1% of patients in pediatrics. It's mainly again for the tacrolimus and the immunosuppressed. And thank you.